I actually, even though this is confusing because there's so much differential diagnosis, I was really excited about this topic because I finally could look at all the different references that are out there, textbooks, articles, guideline practices, condense it all into this one thing and a framework around which you can be consistent about how you approach shortness of breath in the acute care urgent care setting. So let's get to it. I'll start off first with saying, whenever you walk into the room at the doorway before you even see the patient, there's a clear dichotomy of whether or not that patient who's at the urgent care needs to get out of there right now and transfer versus, oh yeah, maybe I'll stay and play. So we'll cover that first and then talk about worst first diagnosis, can't miss stuff, look for the red flags. And after that, we'll talk about some everyday bread and butter stuff that you can take care of and then discharge home. But when we talk about the red flags and worst first, there's a mnemonic that I came up with that I think for me helps frame a lot of how I'm thinking about and systematically and consistently going through shortness of breath because it can be pretty vague. And so it's mouth, lungs, heart, metabolic. And we'll go into that in a little bit.
Yeah, I think there's a difference between, hey, I'm short of breath, doctor, by the way. I was at McDonald's having a burger and I got really short of breath versus short of breath. So big spectrum. Let's bring it home.
Yeah. So first off, when you get in and just open the door and you're just looking at the patient, you want to be able to quickly identify who is sick to get certain balls rolling. And I really like in the Pediatric Advanced Life Support PALS, there's this thing called the PAT triad. And this is basically the same thing, except for more generalized in the sense of airway, breathing, and circulation. But it's not just the airway, it's also about the appearance, specific to shortness of breath. Do they have really noisy breathing? Are they grunting? Are they stridulous? Are they obviously wheezing? Are they tripoding? Are they trying to position their airway anatomy so that they can get the optimal amount of air to get in? You're talking about people who are just, trying to open up the airway as much as they can. Those are really concerning kind of findings. Is their mental status? Are they having decreased response? Are they a little lethargic? Those are all things that you want to take into account because these are patients who probably shouldn't be staying and playing and needs at least a minimum level observation to see if they're going to respond to treatment. B is for work of breathing. And so this is clinical signs that you need to really be aware of and attune to from young children all the way to adults. Having nasal flaring when they're breathing? Do they have retractions like supraclavicular retractions? Are they having intercostal retractions? Do they have abdominal muscle like chest wall, like paradoxical kind of movement because they're trying to recruit more work into breathing? Are they grunting? Do they have a decreased or absent respiratory effort because you can tire out? It's your muscles to help you breathe. It's just like exercising. You do too much work, you can actually fatigue and get tired out. You're not taking adequate respiratory breaths. And then lastly, circulation. Are they cyanotic? Obviously, if they're having mottled skin appearances, you're really concerned about that. Capillary refill and pulses. If they have thready pulses, your cardiopulmonary circulation work in tandem. If you don't get enough oxygen in, if you're not breathing adequately, or if you're exhaling enough carbon dioxide, it can all affect ultimately the circulatory status. And so these are all patients, these are all red flags you need to be aware of as soon as you walk in through the doorway, because these are patients you probably don't want to stay and play.
Yeah, I think about the circulatory part of it because people always say, oh, breathing, it's just the lungs, right? And the airway, lungs and airway. Well, just remember that, the red blood cells, they carry that oxygen. So if those aren't working, no oxygen to the distal periphery. And the pump that's moving that oxygenated blood, if that's not working, it doesn't matter how well your lungs are going or how much oxygen in your lungs, it's just not pushing that blood forward.
So we're going to go into this chart a lot more in detail as we go forward, but just a quick snapshot of where we're headed and how I think about it. Remember, mouth, lungs, heart, metabolic. A person's coming in with a chief complaint of shortness of breath. I'm thinking like outside in. I see their mouth and then go into the lungs. Think about the heart, metabolic. And that's on the left side. And then across the top is the pump, the pipe, and the tank. And so from a lung standpoint, it's like the pump. The lungs are like bellows, a pair of bellows. Think about their pump function as opposed to the pipe, the vasculature supplying the lungs, a tank, the physical structure of the lungs and what might be impeding that. As opposed to the heart, the pump, the heart is a pump, the pipe, the vasculature that's supplying the heart, tank, the actual material or the supply, like red blood cells that supplying the heart. And then lastly, metabolic, just general category, just not to miss.